Hello, I'm Kristen Madison, Associate Professor of Obstetrics and Gynecology at Women and Infants Hospital and Warren Alpert Medical School of Brown University in Providence, Rhode Island. I want to thank ACOG for inviting me to develop these materials for the 64th Annual Clinical Meeting. This is the first of 3 mini-lectures for the flipped classroom session on abnormal uterine bleeding, and the title is Abnormal Uterine Bleeding, Impact, Prevalence, Terminologies, and Etiologies. Abnormal uterine bleeding is defined as any alteration in the volume or pattern of menstrual blood flow. It can be a symptom of an underlying problem with many different etiologies, so anything that interferes with the cycling of hormones, normalcy of the endometrial cavity, or hemostasis can cause abnormal uterine bleeding. Abnormal uterine bleeding is the most common group of gynecologic disorders for which women seek care. Why is AUB important? Medical reasons for concern about AUB are the risks of anemia and the fact that the bleeding may be a symptom of an underlying disease that needs treatment. Equally important is the fact that the lives of women are adversely affected by abnormalities in their menstrual period. Compared to women without AUB, women with AUB are less likely to rate their health as excellent or good. Women with AUB work an average of 3.5 weeks less per year than women without AUB. And this translates into work loss and lost wages. So work loss from heavy bleeding is estimated to be $1,692 per woman. Based on the costs of physician visits, drug therapy, surgical treatments, the estimated total direct cost of AUB is $1 to $1.5 billion annually. If we factor in the lost work wages that I presented previously, the estimated indirect costs range from $12 to $36 billion annually. So it's a very costly problem. Moving on to terminologies and etiologies. Terminologies to describe symptoms, signs, and diagnoses associated with AUB are ill-defined and confused worldwide. This makes communication between clinicians difficult, publications challenging to interpret, and collaborations between investigators nearly non-existent. Because of this, the FIGO Menstrual Disorders Committee developed a nomenclature and classification system to describe the symptom and etiologies of AUB. And this system was approved by the FIGO Executive Board and supported by the American College of OB-GYNs and involves 2 separate foci. One is a simple symptom description, and the other is a classification system for etiologies. The International Expert Panel found major disagreement on use of terms, especially the terms menorrhagia and dysfunctional uterine bleeding, which I've put the traditional definitions of menorrhagia, menomenorrhagia, and dysfunctional uterine bleeding up on this slide. Because of these disagreements, the panel has suggested that these terms are no longer used. They recommended instead a simple descriptive set of terms for bleeding. So the first is heavy menstrual bleeding, the second is irregular and heavy uterine bleeding, and the third is AUB-E and AUB-O. And this underscores the fact that dysfunctional uterine bleeding should no longer be used as a symptom, sign, or diagnosis, based on confusion around its use. And this is replacing it with more precise categories of etiology that we'll discuss a little bit more later in this talk. Another suggestion by this expert group was to standardize how the symptom of AUB is described in terms of 4 clear and consistent bleeding dimensions. Frequency, so periods are described as frequent, normal, infrequent, or absent. Regularity, they're regular or irregular. Duration, they're prolonged, normal, or shortened. And then volume as heavy, normal, or light. Volume is still a bit of a problem when it comes to definitions. Traditionally in research, bleeding was measured by the volume of menstrual blood loss, with greater than 80 milliliters being the definition of heavy menstrual bleeding, or the old term menorrhagia. However, volumetric definitions can be problematic because they're impractical and not used in clinical practice. 2/3 of women who seek treatment for heavy menstrual bleeding actually do not meet this 80 milliliter mean blood loss criteria, which suggests that the actual volume of menstrual blood loss per cycle is not the main reason women seek care for heavy menstrual bleeding. Thinking of a more appropriate and patient-centered clinical definition of the heaviness of heavy menstrual bleeding was well described by the United Kingdom's National Institute for Clinical Excellence 2007 Guidelines for Management of Heavy Menstrual Bleeding, where they defined it as excessive menstrual blood loss, which interferes with a woman's physical, social, emotional, and/or material quality of life. And this underscores the impact that heavy menstrual bleeding has on quality of life and on the woman. Now that we covered the symptom description and nomenclature, I want to briefly discuss the etiology classification system. Abnormal uterine bleeding as a symptom can be caused by several different etiologies, which are included on the slide using the FIGO classification system known by the acronym POM-COIN. The non-structural causes are on the right side of the slide, COIN. On the next several slides, I'll briefly discuss these etiologies of abnormal uterine bleeding that should be considered when evaluating and treating women with AUB. It should be noted that dysfunctional uterine bleeding has been replaced by AUB-E and AUB-O. So AUB-O, bleeding because of ovulatory dysfunction, and AUB-E, bleeding because of endometrial hemostatic dysfunction. And also that although structural causes like polyps, leiomyoma may be seen in the evaluation for abnormal uterine bleeding, they may not actually be the cause. So moving on to the actual etiologies of abnormal uterine bleeding, we'll first start with polyps. Polyps contain variable vascular, glandular, fibromuscular tissue, and it's generally accepted that some may contribute to AUB. But overall, some polyps may be incidental findings, may contribute to AUB, and they may actually spontaneously disappear. Adenomyosis is endometrial tissue that grows within the myometrium. And although adenomyosis is listed as a potential etiology for AUB, the relationship between adeno and AUB is unclear. Adenomyosis can be associated with abnormal bleeding and pelvic pain, but it can also be completely asymptomatic. So again, just because you see one of these structural issues doesn't mean that it's necessarily the cause of abnormal uterine bleeding. Leiomyoma are benign smooth muscle tumors, and they're extremely prevalent. Up to 70% of Caucasian women and 80% of African American women will develop uterine fibroids at some point in their lifetime. However, just like polyps and adenomyosis, frequently their presence is not the cause of abnormal uterine bleeding. So just because fibroids are there doesn't mean that they're actually the cause. Where fibroids are located affects the range of symptoms patients experience in the treatment options. So shown a slide here that has fibroids in the different locations that they can be present. And women who do have uterine fibroids as the cause of their abnormal uterine bleeding can experience heavier bleeding and more extensive passes or blood clots as their main symptom. But again, where it's located affects their symptoms. And the closer the fibroid is to the cavity, the more likely it is to be causing the abnormal uterine bleeding. Abnormal uterine bleeding can be the presenting symptom in women with endometrial cancer and hyperplasia. Endometrial sampling is recommended for women with AUB, first line in all women over the age of 45 years, and in patients younger than 45 years with a history of unopposed estrogen, failed medical management, and persistent AUB. Moving on to the non-structural causes of abnormal uterine bleeding, coagulopathy encompasses systemic hemostatic disorders that may be associated with abnormal uterine bleeding. Hemostatic disorders are more commonly than was traditionally thought until this systematic review by Shankar et al. Was published that showed that 13% of women with heavy menstrual bleeding have biochemically detectable systemic disorders of coagulation. This is why it's important to ask patients about other symptoms such as nosebleeds, gum bleeding, bleeding with prior surgery, bleeding with childbirth, and there are several good questionnaires to screen for systemic hemostatic disorders within the attached reading material published by the American College of OBGYNs. So for the medical management lecture in this series, we will be focusing on AUB-O and AUB-E. So AUB-O is ovulatory dysfunction. Women with AUB-O have bleeding that is heavy and irregular. That's because they don't have ovulation, so they don't produce a corpus luteum, and the ovary doesn't secrete progesterone. This translates into continuous estrogen stimulation without progesterone-stimulated withdrawal bleed. At the level of the endometrium, this means that they have a fragile vascular endometrium with insufficient stromal support, and as one area heals, another begins bleeding. This means erratic, unpredictable, non-cyclic bleeding with inconsistent volume. So in patients with AUB-O, bleeding doesn't occur as a coordinated, synchronous event of the entire endometrium regulated by typical hormone cycling. This is why it's erratic and unpredictable. AUB-E is endometrial dysfunction. These patients have heavy and regular bleeding. This bleeding is caused by local disturbances in endometrial function, so deficiencies or excesses of proteins that have an impact on coagulation. Patients with AUB-E have been shown to have reduced levels of vasoconstrictors and clotting mechanisms and increased levels of vasodilators and fibrinolytic activity at the level of the endometrium. AUB-I, iatrogenic. There are 3 different mechanisms by which medical interventions or devices can contribute to AUB. First, you can have inert or pharmacologic agents that directly impact the endometrium, and examples of this are the levonorgestrel intrauterine system, which can cause irregular bleeding, the CARP or IUD, and then gonadal steroids, such as hormonal contraceptives, can cause breakthrough bleeding. A second mechanism is agents that interfere with blood coagulation mechanisms, so patients who are on anticoagulants such as warfarin, heparin, and low molecular weight heparin. And third, you can have medications that influence the systemic control of ovulation. So, particular examples are medications that interfere with dopamine metabolism, such as tricyclic antidepressants and phenothiazines. And our next slide is not otherwise classified. So several other problems may contribute to AUB, but are poorly understood and currently being further investigated. They also currently do not fit into the other categories, and examples of these are arteriovenous malformations, myometrial hypertrophy, caesarean scar niche or defect, and chronic endometritis. As further evidence becomes available, they could be allocated into an existing category or placed in a separate category entirely. So take-home points for this first lecture on abnormal uterine bleeding is that AUB is prevalent and has a significant impact on quality of life. It's a symptom, not a diagnosis, that can be caused by several different etiologies. And the FIGO classification system for the symptom of AUB and its etiologies standardizes the way that etiologies are described and will facilitate communication between clinicians.